so I feel like I can go on. So you better stop me. Okay, so we just left off about the challenges that patients suffering with dementia experience, and we also looked at what their caregivers go through. Now, the question I always am asked, is there any difference in the suffering of patients with cancer compared to patients with non-cancer? Because all of us, I'm glad that I had a lot of colleagues come up to tell me that the workload that I have where I am is still a lot of cancer and not so much non-cancer. So I often am asked this question, does it mean that my patients who do not have cancer, does it mean they suffer less? Yeah, the answer is no, and let me show you the evidence, okay? Because we are scientists and I wanted to show you the value of what you are doing.
อาจารย์เขาบอกว่ามีเพื่อนร่วมงานของเขาเนี่ยที่ดูแลคนไข้ในกลุ่มแคนเซอร์กับนอนแคนเซอร์เนี่ยเขาบอกว่าถ้าเขาดูแลคนไข้ที่เป็นแคนเซอร์เนี่ยดูเหมือนงานจะหนักกว่าดูแลคนไข้นอนแคนเซอร์มันเป็นการบอกทางอ้อมเหรอว่าคนไข้นอนแคนเซอร์เนี่ยมีความทุกข์ทรมานน้อยกว่าเนี่ยอาจารย์เขาจะเอาหลักฐานให้ดูว่าจริงๆมันเป็นยังไง
So this is actually one of the first studies in 1997, almost 21 years ago. What they did was that they asked the caregivers of patients who were suffering with dementia, and they also asked the caregivers of patients suffering with cancer, and they asked them about the symptoms in the last year of their life.
งานชิ้นนี้ทำในปี 1997 นะคะเขาก็การทดลองเนี่ยถาม caregiver 2 กลุ่มหนึ่งดูแลคนไข้ที่เป็นมะเร็งอีกกลุ่มหนึ่งดูแลคนไข้ที่เป็น dementia แล้วก็ถามว่าใน 1 ปีที่ผ่านมาเนี่ยคน caregiver เนี่ยได้ดูแลคนไข้มีความทุกข์ทรมานอะไรบ้าง
So let me show you the results. So they found that in the last year of life, so the dark bar is patients with dementia. The light bar is patients with cancer. And you can see that in the last year of life, confusion, mental confusion, incontinence of urine, pain, low mood. Constipation is a very big problem, right? Yeah, you don't move very much, you get constipated, so uncomfortable. And loss of appetite. So these were symptoms that were common in both patients with cancer and in patients with dementia. Evidence to show you they do exist. And you know what? Patients with dementia, patients with dementia, you can see that the prevalence is so much higher. This is the percentage frequency. So you can see that patients with dementia have mental confusion far more than patients with cancer. Patients with dementia have incontinence of urine far more than patients with cancer. They have pain far more than patients with cancer. Mood, lower, and I'm not surprised. Constipation, more than patients with cancer. And they also eat poorly more often than patients with cancer.
อันนี้เนี่ยถาม caregiver นะว่าในปีสุดท้ายของคนไข้ก่อนที่เขาจะเสียชีวิตระยะเวลา 1 ปีเนี่ยเขามีอาการอะไรบ้างสีดำเนี่ยก็คือคนไข้ dementia สีเทาก็คือคนไข้มะเร็งก็พบว่าทั้ง2 กลุ่มเนี่ยมีอาการเหมือนกันหมดนะและที่น่าสนใจคือคนไข้ dementia เนี่ยมีความรุนแรงสูงกว่าคนไข้มะเร็งในทุกเรื่อง
So these are some of the challenges that we see in our patients, the symptoms that they have, and they can be pain. And I'm going to show you how we speak for patients. I was asked a lovely question. How do you know that your patient is in pain? She can't tell you. He can't tell you. Remember my police officer who was tied down to the bed? We haven't finished the story yet.
No.
Yeah. So pain. How do you tell your colleague, listen, your patient is in pain, and I'll tell you how much the pain is. The neurocognitive, again, one of us was talking about the behavior, the challenges that we face with our patients with dementia. when you think of dementia, right, a lot of people think of people hitting and biting you. I have a patient, every time I go near her, she pinches me. Function. We talked about increasing inability to walk. A lot of these patients have falls. And the fact that they do not eat and do not drink very well towards the end of their lives. And we need to think about, is a feeding tube always the best option for them? And that's difficult. And finally, the ensuring that they die comfortably, peacefully, ensuring that they have received the best possible care even in the last days of their life, so that their families know that they have done their best, so that their families know that they can carry on.
โอเค ในคนไข้ dementia เนี่ย อันนี้ก็คือความทุกข์ทรมานที่พบในตัวเขานะ ก็จะมีเพนเดี๋ยวอาจารย์ก็จะเล่าต่อไปว่ารู้ได้ไงว่าเขาเพนในเมื่อเขาพูดไม่ได้ แล้วเราจะรู้ได้ว่าเขาเพนเท่าไหร่ ซึ่งเขาจะแลกเปลี่ยนกับเราต่อไป ในเรื่องของไม่รู้เรื่องพูดอะไรไม่ได้เนื่องจากสมองเสื่อมฟังก์ชันเขาก็แย่ลงไปเรื่อยๆกินก็ไม่ดีอันนี้อาจารย์ทิ้งไว้ว่าการให้ NG tube คือทางออกจริงไหมนะคะแล้วก็ตอนวันสุดท้ายคนไข้เหล่านี้เสียชีวิตโดยสงบและไม่ทนทุกข์ทรมานจริงหรือเปล่าเราจะรู้ได้อย่างไร
Okay. So we know that because patients can't speak for themselves, and we know that pain is always poorly managed in these patients, not only patients with dementia. You think about your patients who are mentally challenged. Some of us look after patients, right, who have mental challenges, Down syndrome, mental impairments. Sometimes they can't tell us that they're suffering, but we know they are. So how do we translate that medically? And I'll show you in a while. And we know that when a patient is in pain, what happens to their behavior? What happens to their behavior? It gets worse, right? They get more and more restless because they're trying to tell you, I'm in pain. You're not getting it, so I have to show it to you some way. So I'm going to hit the person. Hopefully they'll get it. That I'm in much pain as I'm causing you. And next thing you know, what happens to the patient? Hide out.
โอเคคนไข้ dementia เนี่ยเขาจะได้รับการดูแลเรื่องความปวดเนี่ยต่ำกว่าที่ควรจะเป็นเนื่องมาจากว่าเราไม่รู้ว่าเขาปวดแค่ไหนเราเลยให้การรักษาได้ไม่เพียงพอแล้วก็พอเขาปวดเขาก็จะยิ่งอยู่ยากแล้วเขาก็ยิ่งอารมณ์ไม่ดียิ่งอยากถีบเตะคนเพื่อให้รับรู้ว่าฉันกำลังปวดอยู่ที่เขาต้องการทำงั้นคือต้องการให้คนอื่นรับรู้ว่าเขาปวดแต่ว่าในหลายๆคนก็ถูกมัดไว้ซะอะไรอย่างเงี้ยแล้วก็ซึ่งอาจารย์เขาจะแลกเปลี่ยนกับเรา
Yeah, so now Napa and I are going to talk to you. How do you know your patients are in pain?
รู้ได้ไงว่าคนไข้
How do they look when they are in pain? Patients who can't speak to you, patients who are, and okay, wonderful, their face, right? All of you look very relaxed, you see, so we can tell, right? You all look very relaxed. But patients who are in pain, faces, grimacing. What else? They stay very rigid. I had a patient, whenever we moved, what happened to them? You can hear like we were like trying to murder the patient behind the curtain. Because the patient would cry, they really cry. And no one stopped. They just carried on.
Aline, may I ask
Yes.
for the dementia patient that they cannot find a word to communicate.
Yes.
But they still can cry.
They can still cry. Crying is God's gift to us to tell us we're in pain. And they can still moan, right? They may not find the words, but you can hear it, right? I'm quite sure all of us we've heard patients in distress. We've all, right? The universal form of distress is crying, moaning, groaning. And when do we hear it more often? When you are turning patients. So I get very upset when my colleagues tell me, oh, Ellen, everything is fine, you look at her, it's comfortable, at rest. At rest doesn't count.
No.
Because you have to nurse the patient, right? I have to turn the patient over, right? I have even some patients who are lying down and they're crying and moaning away, and I'll tell you why in a while. So yes, they definitely grimacing, tense, and when you approach them and you want to examine them, what happens to that tension if they are frightened of you? They get more tense, right? If someone approaches you that you do not know and you are frightened that that person will harm you, what is your stance? You retreat. You go into the shell, right? Like snails, you try to touch them, you go back to the shell. So for patients, they get more tense, they get more rigid. They moan, they groan, they cry. Sometimes what happens to their breathing when you turn them? Because they're in pain. What happens to their breathing? They go faster. I don't understand how we do not see these signs and we carry on. That day I had to stop a nurse from turning my patient because the patient was crying, and the nurse was saying, Dr. Ham, you're really slowing me down. I have a task schedule. I have to clean the next 6 patients by 2 o'clock and give medication, so my poor nurses are really overworked. Yeah, so I said, okay, I'll stay with her. You go and clean the other patient. We'll give medicines first. Okay. What else do they show when they are? So let's say, Napa, if you're crying, right, and I stop what I'm doing, right? What do you all do when patients are crying? Touch them, right? You try to try to stop, right? First thing, stop, right? First thing, stop doesn't happen usually. So stop. If the patient doesn't stop crying, what does it mean? It's pretty bad. That means that even when you stop what you're doing, you're trying to console them, they are inconsolable. So these are all ways that patients are speaking to us and telling us, listen, I am suffering and you are making it worse.
โอเคอาจารย์เขาบอกว่ารู้ได้ไงว่าคนไข้ปวดนะก็มีคนตอบว่าก็นั่งดิ้วคิ้วขมวดอันที่ 2อาจารย์ก็บอกว่าดูจากภาษากายเขาอาจจะรู้สึกแบบไม่ตัวแข็งไม่อยากเคลื่อนไหวแล้วเวลาเราเข้าใกล้ก็ยิ่งถอยห่างอะไรเหมือนกับที่อาจารย์เขาทำหรือเวลาเราจะพลิกท่าหรือทำอะไรเขาก็จะอาจจะแบบคลางออกมาหรือแม้แต่ร้องไห้เขาพูดเป็นคำไม่ได้แต่เรื่องการร้องไห้เนี่ยยังคงสามารถสื่อสารได้เพี้ยนเราได้ยินไหมคือเราอยู่ตรงนั้นแต่บางทีเราละเลยไงเพี้ยนอาจารย์เขาบอกว่าถ้าเกิดเหตุการณ์งั้นสิ่งที่เราควรต้องทำคือหยุดการทำทั้งหมดนั้นที่ทำให้เขากำลังสื่อสารกับเราว่าเขากำลังปวดอยู่นะแล้วก็พยายามปลอบเขาซึ่งอันนี้อาจจะขัดขวางการทำงานของพยาบาลเขาต้องไปทำอีกหลายเตียงอะไรอย่างเงี้ยถ้าคุณเป็นหมอคุณก็บอกพยาบาลว่าก็อาจจะให้เขาไปเตียงอื่นแล้วเราดูแลคนไข้คนนี้ต่อเพราะว่ามันไม่มีประโยชน์ที่จะเดินหน้าต่อโดยที่คนไข้ยังปวดอยู่
So these are patients who we call the silent suffering, and I'll show you how we can speak for them. Okay, so this is a scale that was actually developed. One of many scales. So when we try to help our colleagues identify patients with dementia, find a tool that you know your colleagues will use. And you must remember, all of us are very busy, right? Colleagues, our nursing and our medical colleagues are very busy. So you need to find a tool that will help them pick up the patient. You need to find a tool that will help them speak for the patient. And this is a simple tool that we have been using in Tan Tock Seng and in our home care for advanced dementia. It's called the pain assessment in advanced dementia. So it's called the PaNAD, P-A-N-A-D, pain assessment in advanced dementia. But let me tell you, I use it in advanced cancer patients who are delirious. I use it in any cognitive impaired patient who cannot speak for themselves because the principles hold. And the principles hold in 5 areas that all of us, and let me tell you, it was developed from our nurses, their observations. So what are these observations? Look at their breathing pattern. And this must be used at rest and on turning. Very important. I always ask, what are they like when they turn? So is the patient breathing normally? They are breathing normally. The score from 0 to 2 is 0. If you turn them and they start to breathe, in a very uncomfortable manner, but it's not too long, it's about 1. Total score can be 1. If they start to breathe faster, the more uncomfortable they are, it will be 2. Okay, so the breathing can be from 0, where there's normal, on rest or turning, to as bad as 2, which is highly uncomfortable. Negative vocalization means the moaning, the groaning, the crying, the ah! You know, I had a patient who was like, you've heard it all, right? Yeah, and then these are the ones that, oh my gosh, what's happening behind that curtain? So it can be none, where, you know, where you turn your patient and the patient who has, you know, contractured, but, you know, Dr. Shriving started on fentanyl, so now I turn patient so comfortable. No, nothing. No negative vocalization. When you turn the patient, okay, oh, you know, occasional moan and groan, about 1 point. Okay? Or they will like, you know, ah! You've heard that, right? See, you don't have to be Thai or Singaporean. These are universal signs of distress. They do not need translation. Then the repeated calling out. Ah! Stop. So that will be 2. Okay? So you can put 2 here. Facial expression. We tell a lot, you know. We know that when we communicate both verbally and non-verbally, right? We teach our colleagues communication skills in medicine. It's really not only about what you say, it's about what you do not say as well. And our patients, we are not looking at what they are not saying to us. So you can tell that they are grimacing, you know, they are like, and then I like to ask, because when I see my patients and I say, that face looks okay to me, then the person who really tells me whether it's okay or not okay is the caregiver. Does she always look like this? And it's always wonderful to get them involved. Like, does your mom look comfortable? Do you think this is her facial? Oh yeah, this is how my mom is when she's sleeping. Or families will tell you, no, I don't think my mom looks comfortable. Something is wrong. I'll get to it. Facial expression. So they can be very smiling. You might say, but Dr. Ham, if it's 7E, no smile, or 7F, no facial expression. I have never met a patient who cannot smile or inanimate who cannot grimace at me. They can. Alright, so I never believe that. So they can be smiling or inexpressive, which means okay. They can be sad, they look sad, frowning. So sometimes you have to actually ask families, does your mother look sad to you? How many of us ask our families, does your father look sad? Does your grandmother look sad? My grandmother suffers from dementia. It took a colleague to tell me that, do you know your grandmother looks quite sad? I didn't know. So ask your caregivers. So if they are sad, it's about 1. Facial, if they're grimacing, it's 2. And if they don't stop grimacing, it's probably more than 2, but it's 2 here, okay? Then the body language, all very relaxed, right? Patients. Then when you start to approach them, they start to tense. And then when you start to turn them, they move like a plank, right? The orthopedic surgeon will say it's called one single joint movement. Right? They don't seem to be able to, because many of them are contractured. And contractures hurt. They really, really hurt. So if they are relaxed, it's 0. If they're tense or they get rigid, the score goes higher. Of course, if they strike out and they push you, they pinch you. I had a patient who spat at us. So that's even worse. And the last section is consolability, where there's no need, or if they can console, okay, good, you can rescue this situation. It's harder if they do not stop crying, they just moan and groan. That's bad. So these are the 5 categories. Think about it, it's very easy to apply at the bedside, right? You don't need to memorize it. It's basic nursing care, basic medical care that we don't do. You know when I started using this PaLLintive, I had fully qualified as a PaLLintive doctor before I used it. Can you believe it? So what have I been advocating for my patients all these years? And I also use it in patients with cancer who are delirious. Because patients who have cancer, they can't tell you very much too, right? So we think about it. They look at their breathing pattern. Are they groaning and moaning? How do they look to you? How do they tense? And whether you can console them. And for caregivers, when they often ask me, Aline, how can you tell that my grandmother is in discomfort? Then I share with them. you know, your grandmother was actually, her face, she looked deeply unhappy. When I turned her, I could hear this, there was soft moaning, soft groaning. I noticed her breathing seemed to increase, and that to me was a sign of discomfort. When families hear that and they listen to you, then they start watching closely. They learn from you, so that at home, they can call you and say, you know what, I've observed the same thing that you have observed. So now, before I turn my mother, I make sure I give pain medicine first. I make sure I tell my mother, Mom, I'm going to turn you. You know, sometimes when I'm in the hospital, you know, and the patient doesn't know me, right? I take the daughter. This is your daughter. She's going to help me turn you. So there's less fear. Because, oh, I don't know who this person is, but I know who this young lady is. I don't know her name, but I know she loves me. And, you know, so you really need to know the illness and you know how to respond to it. Okay? Now, I've said a lot and Napa will translate, but I hope you get the gist by watching me.
Yeah, agree.
So a lot of people will tell me, okay, so Ellen, how do I use the score? The score, what's the maximum score? 2 plus 2 plus 2 plus 2 plus 2 is 10. 10, right? It's almost like your numerical rating score, right? But let me tell you, of course we think that the higher the score, the worse it is, right? But for our patients who have cognitive impairment, any score, 1 is bad enough. 1, you need to address it. It doesn't mean if it's 1, it's 10. 10 means I must address it. 1, any score, because your patient is so vulnerable.
โอเคเครื่องมืออีกเครื่องหนึ่งชื่อ PaLLintive นะก็ย่อมาจาก Pain Assessment in Advanced Dementia ก็เป็นเครื่องมือที่อาจารย์เขาคิดว่าใช้ได้ง่ายนะก็จะประเมินคนไข้อยู่5ด้านด้วยกันตอนขณะที่เราพลิกตัวคนไข้เราจะดูว่าการหายใจเขาเป็นยังไงถ้าขณะพลิกตัวเนี่ยคนไข้ก็หายใจด้วยความเร็วปกติเสียงอะไรทุกอย่างปกติก็ให้เป็น0ถ้าเผื่อว่ารู้สึกหายใจแรงขึ้นเร็วขึ้นแต่ว่าไม่มากอะไรอย่างเงี้ยก็ให้1ถ้าเผื่อว่าหายใจเร็วขึ้นแรงขึ้นยาวนานขึ้นรุนแรงก็ให้2ทีนี้เราก็ดูแล้วเราก็เลือกว่าเราจะให้ตัวเลขเป็นอะไร Negative vocalization เนี่ยหมายถึงการครวญครางไม่ได้พูดเป็นคำออกมาการครวญครางก็แล้วแต่ถ้าไม่มีเลยก็ให้เป็น0ถ้าเผื่อว่าครวญครางเป็นแบบที่ฟังแล้วว่าเขากำลังเจ็บปวดเนี่ยนะแต่ว่าไม่มากหรือตอนพลิกนี่นานๆทีไม่ได้ตลอดเวลาของการพลิกก็ให้1ถ้าเผื่อว่าดังแล้วก็ถึงแม้กระทั่งร้องไห้ตลอดการพลิกก็ให้2การแสดงสีหน้าเป็นยังไงถ้ายิ้มแย้มหรือไม่ได้แสดงสีหน้ายิ้มหรือว่าไม่ยิ้มเฉยๆก็ให้0แต่ถ้าเผื่อสีหน้าแบบว่าเศร้าหรือแบบตื่นตกใจอะไรอย่างเงี้ยก็ให้1หรือขมวดคิ้วถ้าเผื่อแบบว่าเป็นแบบหน้านิ้วคิ้วขมวดอย่างยิ่งก็ให้2ภาษากายเขาเป็นยังไงดูก็ผ่อนคลายดีก็ให้0ถ้าเผื่อรู้สึกแบบว่าแข็งทื่อหรือถอยห่างอะไรอย่างเงี้ยหรือแม้แต่แบบกำหมัดหรืออยากจะแบบมีปฏิกิริยาชกกับอะไรอย่างเงี้ยหรือแสดงท่าทางมากมายขึ้นก็ให้เป็น2 consolability แปลว่าการปลอบโยนถ้าเราสามารถเขาไม่ต้องการการปลอบโยนก็ให้0ถ้าเผื่อว่าเขาครวญครางหรือแสดงอาการบอกว่าเขาไม่สุขสบายนะแล้วเราปลอบโยนเขาด้วยเสียงหรือการสัมผัสแล้วเขาหยุดก็ให้1ถ้าเผื่อปลอบโยนไม่ได้ยังคงเดินหน้าครวญครางต่อก็ให้2เพียงตัวเลขคะแนนสูงสุดที่เป็นไปได้ในตารางอันนี้คือ10ใช่ไหมคะมันก็คล้ายๆกับที่คุณตรวจกันนะให้คนไข้บอก1 ถึง 10คุณอยู่ตรงไหนอะไรอย่างเงี้ยแต่ในกรณีเพนแนปเนี่ยในคนไข้ดิเมนเชียซึ่งใช้กับคนไข้มะเร็งระยะสุดท้ายได้ด้วยนะใช้ตารางนี้ได้แม้แต่คะแนนเป็น1ก็ต้องเข้าไปให้การดูแลแล้วเพราะว่าเขาไม่สามารถบอกอะไรได้อะนะคะ
So do you think that this is something you could use?
คิดว่าไหม practical ไหม
Practical, right? Definitely, right? I have to say that, having been in the position to try to develop care for patients, and many of you will do your own services, it is really important to try to make it as simple in terms of delivery.
Yeah.
Yeah, you really want to try to speak in a manner that really educates not only your colleagues but your caregivers.
yeah
Yeah.
อาจารย์เขาบอกว่าการที่เราจะเอาเครื่องมืออะไรออกไปใช้เนี่ยให้เราตระหนักเสมอว่ามันง่ายต่อการใช้กับ caregiver ด้วยนะเพราะเขาคือกำลังสำคัญเขาจะสามารถบอกรายละเอียดอะไรบางอย่างให้กับเราได้เพราะว่าเราไม่ได้อยู่คนไข้ตลอด 24 ชั่วโมงอีกอันนึงก็คือว่าที่อาจารย์เขายกตัวอย่างเนี่ยเขาไปดูแลคนไข้ที่เป็น dementia แล้วก็เขาก็บอกกับ caregiver บอกว่าคุณแม่ของคุณเนี่ยกำลังเจ็บปวดอย่างยิ่งอะไรเงี้ยคน caregiver ถามว่ารู้ได้ยังไงก็เขาพูดไม่ได้แกก็เลยพา caregiver เนี่ยท่องเที่ยวไปกับตารางเนี้ยสังเกตไหมตะกี้นี้คุณแม่คุณมีอาการอย่างนี้ตอนที่หมอพลิกนะเขาสีหน้าท่าทางเป็นไงเขาครวญครางหรือเปล่าเขาอะไรอย่างเงี้ยก็บอกไปด้วยเพราะฉะนั้นก็ทำให้แคร์กิฟเวอร์เขามีความเข้าใจว่าเราสามารถรู้ว่าคุณแม่เขาอยู่ในภาวะใดโดยใช้เครื่องมืออันนี้ช่วยเพราะเขาไปดูแลที่บ้านเขาสามารถที่จะประเมินได้แล้วก็กลับมาโทรศัพท์กลับมาคุยกับหมอว่าเขาคิดว่าคุณแม่ของเขาตัวเลขของตารางนี้คืออะไรเพียงเวลาคุณใช้ตารางนี้แล้วมีแคร์กิฟเวอร์อยู่ก็เป็นสิ่งที่ดีนะที่จะคุยให้เขาฟังว่าเรากำลังทำอะไรเพื่อให้เขาเกิดการเรียนรู้ด้วยI explained them more about that. You said that you talk to the caregiver. How can you use all this, and they can do it by themselves at home, and then they can communicate with you more precisely about the
This is very helpful in home care because sometimes when we do telephone check-ins, we live very far apart in Thailand, not in Singapore but in Thailand. Sometimes it's good to ask your family. How's your loved one? So sometimes your family will say fine. So I'll ask them, is your father frowning? Because the last time I visited, your father was frowning. Is he crying when your daughter turns him? So when you are able to speak like that, you are teaching the family slowly. I am also very encouraged to see my medical colleagues. Doctors are the hardest to teach. Once they learn something very hard to unlearn. Nurses are very good. So once doctors, very very obstinate we are. I speak as a doctor. So the thing is that when you teach them that, look, your patient's pain net is 7, and I'm going to start a medication that can help, and you can see that the patient looks more comfortable. It makes a world of difference. A lot of doctors feel that they have failed their patients. And what we're trying to tell them is, if you never leave their side and you try your best, you never fail them. Right?
Right. สรุปก็คืออันนี้ดีมากเลยนะสำหรับการดูแลคนไข้ที่บ้านก็ทำให้ caregiver เนี่ยเขามีเป้าว่าเขากำลังดูอะไรอยู่แล้วไอ้ที่เขาเห็นเนี่ยมันแปลความว่าอย่างไรแล้วเวลาโทรเข้ามาปรึกษาซึ่งบ้านเมืองก็จะอยู่ห่างไกลกันใช่ไหมมันจะได้มีจุดร่วมกันว่ากำลังพูดเรื่องอะไรกันมันจะได้สื่อสารกันตรงเรื่องแล้วก็ให้คำแนะนำหรือความช่วยเหลือที่ชัดเจนมากขึ้นนะคะ
Okay, so back to my patient, okay, because you asked me a beautiful question, how do I speak? So this is how I speak to him. So when I went to see him, he was angry looking. Can you imagine? He was restrained first of all. Of course he would be angry, right? A mask had been placed on his face. Why do you think that a mask had been placed on his face? Thank you. He kept spitting at the nurses. He was so angry, Napa. If you put a mask on me, I will spit at you as well. He was trying to get across, this is not how I want to be. The doctors barely could examine him because every time they approached him, right, he would get very frightened and he would try to hit them. And they didn't bother telling him what they were going to do. They just put their stethoscope, pat his tummy. Okay, patient looks unhappy. Afebrile, BP okay. His tummy is soft and non-tender. Dr. Han will come and wow. Those are notes we see in Thailand as well, right? Yes? Same in Singapore.
พออาจารย์เข้าไปพบมิสเตอร์พีรู้ได้ยังไงมิสเตอร์พีบอกเขาได้ยังไงในเมื่อมิสเตอร์พีพูดไม่ได้อาจารย์บอกว่าเนี่ยไงเขาบอกหมดนี้เลยก่อนอื่นเลยทันทีที่เห็นคือเขาถูกผูกแขนขาใช่ไหมเขาก็เลยดูแบบโกรธอย่างยิ่ง แล้วก็แถมยังมีแมสปิดไว้ที่หน้าอีกเพื่อกันไม่ให้เขาถมน้ำลายใส่ทีมสุขภาพไม่น่าเชื่อเนาะแล้วเขาก็เวลาที่ใครจะเข้าไปทำอะไรเนี่ยคือสภาวะเขาเห็นทุกคนเป็นคนแปลกหน้าหมดเพียงเขาก็จะกลัวหรือแม้แต่แบบตอบโต้กลับเขาคิดว่าจะเข้ามาทำลายเขาหรือเปล่าก็เลยกลับไปที่คนไข้เดิมของอาจารย์เขานะที่เขาจะช่วยพลิกคนไข้และคนไข้แบบกลัวอะไรอย่างเงี้ยสิ่งที่เขาทำคือเอาลูกสาวมาอยู่ด้วยเพียงเขาจำลูกไม่ได้ไม่รู้คุณคนนี้ชื่ออะไรแต่คุ้นหน้าก็ทำให้คนไข้สงบลงไปได้เยอะเพียงการที่เอาลูกสาวมาอะไรก็อาจจะเป็นเทคนิคอันหนึ่งที่ดีนะแล้วก็หมอที่ไม่ใช่เป็นผู้เชี่ยวชาญเนี่ยแต่ต้องมาราวเตียงนี้ก็อาจจะตัวแตะกดจบแล้วก็เขียนว่าเจออะไรแล้วก็เดี๋ยวรอมิสคุณหมอหามมา หมดหน้าที่เขาก็ไป
Pass the case on. And he was granting an exam. So how will you manage instead?
จะจัดการยังไงดี
Okay, come. Let's all try. How
จ
will
ริง
you
ๆต้องทำยัง
manage?
ไงดี
So you are now the person they say, okay, you're coming to see. What will you do first?
ไปเห็นมิสเตอร์พีจะทำอะไรก่อนเลย
Yes.
Greeting
Very good. Tell him what you are. Yeah. What else?
แนะนำตัวบอกว่าฉันคือใคร
Say hello. Very important. Yeah. Be very gentle and they cannot take when there are many voices coming at them. So one voice.
อย่าพูดเยอะแยะอย่าพูดหลายคนจะยิ่งงงเอาคนเดียวพูดพอ
So when you're turning or you're examining, one voice. Because when there are too many voices, they get very scared. If there's a family beside them, ask the family to sit beside you, stand beside you, and to ask the family to tell them, this is doctor who and who, this is nurse who and who, and she's here to come and take care of you. And the daughter or the family caregiver will be the comfort to the patient. So use the family. In Singapore, right, it's very interesting. We actually ask the family to leave the exam, go out of the room, same the same. Now, in dementia, we need to think differently. We need to use their loved ones. Their loved ones are not against us. Their loved ones want you to take the best care of their loved one. So sometimes I take them along. I say, can you, I'm going to do this to your father. You just tell him, don't be scared. I'm going to just, undo his shirt. I want to see his chest. I want to listen to his chest. You hold his hand while I examine so he's not so frightened. So that's something you used to, because they don't know you. I may have Mr. P's doctor for many years, but he is delirious. He is confused. He doesn't know who I am. He will probably spit at me, and I deserve it because I'm not adapting to him. I'm expecting him to adapt to. Yeah, I should adapt to him. I should be considerate of his illness and the fear that is in him, and I should come, greet him, say hello, tell him what I'm doing. If there's a caregiver, can you help me? Come, reassure him, hold his hand, and then tell him step by step what I'm going to do. So use that. That's something I've learned. Not too many voices too. One voice. So if my nurse speaks, I will just whisper, can you tell him I'm going to do this now?
Okay. อาจารย์เขาบอกว่าสิ่งที่ต้องทำนะก็คือว่าก่อนอื่นเลยต้องใช้เสียงเดียวอย่ามีหลายเสียงคนไข้จะสับสนแล้วคนไข้จะกลัวให้ใช้เสียงเดียวเช่นถ้าเราไปราวคนไข้ในวอร์ดแล้วพยาบาลเขาอยู่ตรงนั้นเยอะกว่าเราคนไข้น่าจะคุ้นชินกับพยาบาลมากกว่าเอาพยาบาลอยู่ด้วยกันแล้วก็ให้พยาบาลเป็นคนสื่อสารกับคนไข้บอกเขาว่านี่คุณหมอนะกำลังจะมาเดี๋ยวจะตรวจร่างกายทำอะไรต่อไม่ได้ให้พยาบาลคนสื่อสารหมอกลับจะไม่พูดนะคะหรือถ้าเผื่อบังเอิญเห็นมีญาติเอาญาติไปด้วยกันเลยแล้วให้ญาติเป็นคนพูดว่าโอเคคุณพ่อนี่คุณหมอนะเดี๋ยวเขาจะมาทำนู่นนี่นั่นคือให้ลูกเป็นคนทำแต่ว่าเขาให้ลูกเป็นคนพูดแล้วเขาเป็นคนทำอย่างนี้คนไข้จะไม่ตื่นตระหนกมากนะคะ
What will you do next?
แล้วทำอะไรอีกยกเว้นว่าทักทายแนะนำคุณหมอนู่นนี่นั่นคุณหมอจะมาทำอะไรโดยเสียงเดียวแล้วเราจะทำอะไรต่ออีก
What else did you do? This is your patient now.
ทำอะไร
Just tell me what you would normally do in the ward. Don't worry, no mistakes, because we're learning from each other.
so what do you want to do หนูแหละตะกี้หนูตอบเลย
What would you like to do?
อะไรนะอ๋อ she would like to untie the patient
Thank you.
อ๋อขอบคุณพระเจ้า
I will remove the restraints immediately.
จะแก้มัดคนไข้ทันที
Yay! Someone to untie him.
โอเค
Yeah, remove the restraints. We know that when you restrain patients, they get more agitated.
Yeah.
There is absolute evidence to support this.
มีหลักฐานชัดเจนว่าการมัดคนไข้ทำให้คนไข้ยิ่งพลุ่งพล่าน
In fact, I want to tie everyone down in medical school. I want to show them what it's like to tie your patients. You know, in my hospital, right, my nurses tie my patients better than they do anything in the world.
Wow!
If they actually tied my knots in bungee jumping, I will be happy to jump off. It's so tight. It's so
อาจารย์เขาบ
tight.
อกว่าไม่มีพยาบาลของเขานะ คนหนึ่งนะมัดคนไข้ได้ดีที่สุดเป็นงานที่เธอทำได้ดีที่สุดบนโลกใบนี้ มัดได้แน่นมาก
What's next? Doing very well.
ทำอะไรอีก greeting แล้วโดยเสียงเดียวแล้ว
Remember he's a mask,
แล้ว
right?
อ๋อ
Okay, well, I can spit that, but it's very disrespectful to mask somebody, right? Remove the mask. Thank you.
เอามาสก์ออก
He's been made to feel like a criminal, right?
โอเค
Yes.
เอามาสก์ออกแล้วอะไรอีก
Mask off, restraints off.
What and the NG tube Thank God
Okay, does anybody want to ask me the feeding tube, right? Because the doctors were they would say, and these are my fellow colleagues, they would say, but Ellen, he can't swallow, he's got dysphagia, swallowing impairment. So this happens in a lot of our patients. And I will basically cover this tomorrow, but there is a lot of evidence to show that eating at the end of life and tube feeding actually does not shorten your, it doesn't lengthen, I beg your pardon, doesn't lengthen your lifespan. Thank you. Does it make the quality of life better with the feeding tube?
No
You know what Mr. P told me? I asked his daughter Mary, what would Uncle say if he had the feeding tube? She was crying. You know, she was saying he would never have wanted this. And I told her, Mary, if I remove this and I let your father eat, I will feed him very slowly. I will make sure he sits upright when he eats. I will teach his helper, who is like a daughter to him, to feed. Both feeding and tube feeding, same risk, but one, he'll be happier.
Yeah.
So she looked at me, Ellen, there's no decision to make. He wants to eat.
โอเคเอา NG tube ออกสืบเนื่องจากคุณพีเนี่ยเขาชอบกินใช่ไหมคะเพราะฉะนั้นเนี่ยมันเป็นความสุขอย่างหนึ่งเขาก็คุยกับลูกสาวบอกว่าจะเอา NG tube ออกนะเพราะมีหลักฐานบอกว่าให้ทางสายอาหารก็ไม่ทำให้ชีวิตยืนยาวคือลูกสาวบอกว่าอันนี้ไม่ต้องการตัดสินใจเอาออกได้เลย คือไม่ต้องคิดไม่ต้องพูดมากอะเอาออกได้เลย
So this is where you need to practice evidence-based medicine with, so it's marrying evidence-based with your patient's goals and values. So people might say, you know, Ellen, this is unethical. How dare you not feed your patient? But we have lots of, you've heard it, right? So we really need to be courageous. We need to read. That's why I always tell my junior doctors, you need to read and do the research. You need to show people no evidence that life is prolonged with artificial feeding. No evidence to show that one's suffering is reduced. And feeding orally, slowly, putting into attention the posturing is just as effective. And when you feed a patient, as when you hold a thing, how you show love when you feed a patient, right? You take care, right? But it is not easy. And let me tell you the conversations I've had with my families about tube feeding. Because tube feeding, just put in, right? It's the symbol that there is medical care.
อาจารย์เขาบอกว่าพวกเรามีความจำเป็นนะที่จะต้อง เรียนรู้ตลอดเวลาและต้องมีหลักฐานทางการแพทย์ที่จะบอกกับครอบครัวหรือเพื่อนร่วมงานว่าอย่างกรณี NG tube เนี่ยมันมีการวิจัยเยอะแยะบอกว่าการให้สารอาหารไม่ทำให้คนไข้อยู่ได้นานขึ้นคือเราต้องพูดอย่างกล้าหาญไม่ใช่อ้ำอึ้งเพราะว่าไม่รู้อะไรอย่างเงี้ยแล้วผลที่สุดมันก็คนไข้ก็จะถูกใส่ NG tube อะไรอย่างเงี้ยเราจะได้ยินคนพูดถึงว่าเราไม่มีจริยธรรมที่ไม่ให้อาหารซึ่งอันนี้เป็นความคิดสมัยเก่าเราต้องบอกว่าหลักฐานขนาดนี้มันคืออะไรการที่ป้อนคนไข้แต่ต้องสอนนะว่าต้องป้อนคนไข้อย่างไรต้องช้าๆคำเล็กๆเอาคนไข้นั่งตรงแล้วก็มันมีวิธีก็แล้วกันแล้วก็ทำแบบนั้นแล้วก็การที่ขณะป้อนเนี่ยก็เป็นการที่แสดงถึงความรักของผู้ดูแลต่อคนไข้ด้วยเพราะฉะนั้นเป็นสิ่งที่ควรจะทำแทนที่จะใส่ NG tube.
So when we did all this, he was so much calmer that he actually allowed me to examine without spitting at me.
Okay.
Yeah, and what I found was that he had a lung infection that we were treating, but he kept pulling out his IV. So we basically blended the augmentin. We gave him augmentin syrup. We also found he was very badly constipated, and he wasn't having urinary retention, but he was close to it. So we cleared the bowels. Okay, all right. So these simple measures made it, and I made sure that his caregiver stayed with him as well to give him some comfort.
ก็คือสรุปทำทั้งหมดบนฟลิปชาร์ตโดยที่มีลูกสาวอยู่ข้างๆก็เลยทำให้ทุกอย่างเนี่ยลุล่วงไปได้ด้วยดีพอทำจนถึงเอา NG tube ออกมิสเตอร์พีก็สงบพอที่จะให้คุณหมอฮามตรวจร่างกายอย่างดีแล้วก็จะทำอะไรก็ทำไปอะไรเงี้ยค่ะ
So I discharged him on hand feeding, and I asked a colleague who was doing PaLLintive medicine, home care, to help me to look after him at home because the daughter and I talked about what Mr. Prakasam would have wanted, and she said that he would never want to come back to the hospital if he was treated in this manner, that the antibiotics she knew would not keep the infections away, and she chose that, if my father were to live at home eating with the family and being cared for, this is what we want. So because palliative care for dementia was not developed, I was in constant contact with the community nurse, and Mr. Prakasam passed away at home 6 months later in his home. He had another infection that we treated with oral antibiotics, but after that he continued to still get weaker. So when he had another fever, we decided no more. And his daughter, he passed away very peacefully with all his children, his grandchildren. After he passed away, he brought chicken rice for the whole department. He bought so much, he actually told his daughter that when I die, I want to make sure that Ellen's department eats chicken rice, and he bought us so much that we could actually bring it home for our families.
หลังจากนั้นมิสเตอร์พีก็ดิชาร์จกลับบ้านได้แล้วก็ไปดูแลที่บ้านมีอินเฟคชันครั้งหนึ่งก็ให้แอนติไบโอติกทางปากก็โอเคพอหลังจากนั้นมีอีกครั้งหนึ่งก็คุยกันกับครอบครัวก็คิดว่าคงไม่ทำอะไรแล้วในที่สุดมิสเตอร์พีก็จากไปด้วยความสงบแล้วก็เคยสั่งเสียลูกไว้ว่าถ้าจากไปเนี่ยให้ซื้อข้าวมันไก่มาเลี้ยงดีพาร์ตเมนต์ของคุณหมอหามด้วย
Chicken rice
แล้วก็เขาก็ซื้อมาเลี้ยงมากพอที่ให้ทุกคนห่อกลับบ้านได้ด้วยนะคะ
Okay.
มีใครจะฝากธุระแบบนี้ไหม
Simple things is back to good medical care. That's what palliative medicine taught me. It taught me to really love what I do as a doctor. Okay, so let's go on to another case, alright? Okay, again, all these are my patients. She's still with me. This is a patient of mine that I've been looking after for the last 3.5 years. Quite amazing, I know. She's a very young dementia. She developed it when she was very young, very sad. There's no family history, but she had the behavior symptoms of dementia that we will talk about immediately after this. She was in fast stage 7C for the last 5 years. So 7C, that means advanced, right?
Right.
Yeah, unable to sit up by herself. So she was bed bound. And she was on tube feeding for the past 4 years. Very sad. Okay, I shouldn't show you that first. So when I first went to see her at home, there was constant moaning and constant groaning, very low. It was not chanting. She's a Buddhist, but that was not chanting. I could even hear it before I entered the room. I was like, oh, you know. And I asked the helper, when you turn her, how does she sound? Even higher pitch. And this also, do you think she could sleep?
No.
She didn't sleep. She didn't sleep. So this was what happened. The orthopedic surgeon would tell me she has osteomyelitis.
Osteomyelitis.
Would you operate?
ผ่าไหมหมอออโทหมอเมียง
She kept getting fevers. But she also had ischemic heart disease. She had AF.
The answer is no.
This is a sensible surgeon, very loving surgeon. So sometimes it's much harder to say that you will not do certain things. You know, it takes a lot of courage. I salute my colleagues who are able to stand by their decisions and say that, you know, we are guiding you, and I think that it's really, it was hard because the families had heard so many comments, said operate, not to operate. This is her 4 years down the road. I'm still looking after her with this. 4 years. 4 years. So, okay, so you see this patient who's moaning and groaning. My surgeon sensibly tells me, even if I operate, it may not relieve the pain. It's not going to relieve the fever, because you can get fever from the aspiration. You can get the fever from the urine infection. Napa, do you want to translate?
Yeah. Mrs. Y เนี่ยคุณผู้หญิงชื่อ Y เนี่ยยังคงมีชีวิตอยู่นะ อาจารย์เขาดูแลมา 4-5 ปีแล้ว แล้วก็เธอโชคร้ายที่เป็นดิเมนเชียตั้งแต่อายุน้อย แล้วก็ตอนที่เธอไปพบเนี่ยคนไข้ก็จะครวญครางเสียงต่ำๆซึ่งมันไม่ใช่การสวดมนต์นะเธอเป็นชาวพุทธแกก็บอกว่าอย่าไปหลงว่ากำลังท่องบทอยู่ไม่ใช่ แล้วก็ถ้าเผื่อว่าไปพลิกเพลิกอะไรเนี่ยเสียงนั้นก็จะยิ่งดังมากขึ้นอะไรอย่างเงี้ยแล้วก็พอพลิกดูก็พบแผลที่ก้นกบแบบนี้นะคะ
So this is an unstageable sore. You know we have stage 1 to stage 4, right? Yeah, this is unstageable. Completely cannot stage. Yeah, so okay. So I always, when we go and see patients in the home, when we go and see patients in Tan Tock Seng, when I have patients in Dover Park Hospice, we always start by asking ourselves, what is the pain score, okay? I know that, you know, the patient's in pain, but the reason why we chart is that if I'm going to institute treatment, I might not be the doctor seeing the next time. So my colleague can see and say, hey, you know, Ellen instituted treatment and this is currently the pain score, so it made a difference. So let's think about what the PNET score. So she was moaning and groaning, and it was just persistent. So the negative vocalization was 2. Thank you, dear.
Yeah.
Negative vocalization was 2. Okay, anyone want to ask me about her facial grimacing?
เราก็จะประเมินคนไข้โดยใช้เพนแนดูสไลด์อันนั้นควบคู่ด้วยก็ได้เนาะเพราะฉะนั้นเนี่ยnegative vocalization คือครวญครางได้ 2 เพราะว่าเธอครวญครางตลอดเวลาใช่ไหมมีอะไรอีกอยากจะถามอะไรไหม
So her face was like
หน้า
constantly.
ก็เป็นแบบนี้ตลอด another 2
What's next? Posturing, thank you. Okay, so Madam Y was contractured.
อยู่ในท่าแบบว่างอกองอคิง
When we turned her, she tensed up even more. And she was crying when I turned her.
another 2 so it is 10 out of 10
Almost not yet, but we need to know.
Really?
Organization. Okay, what's the other 2 that I'm missing? Breathing, right? The respiration, right? So the respiration didn't really increase when I turned. Yeah, so my nurse rated her as 1 out of 2. Just slightly faster, but when we stopped the turn, she was okay. So the breathing didn't persistently go on.
Just one.
Yeah, so just 1.
Consolability.
Thank you.
How is it? Cannot be consoled. Okay, 2 out of 2.
Her helper was close to quitting.
Uh,
She couldn't take it anymore. Helper looked after her for the past 5 years. So she was also emotionally very upset.
Yeah.
And the family was saying, oh, but she's always like this. So you can see that the score is about 9 out of 10, right?
Right.
Yeah, and we say that, you know, any score is important, but for her, there was something that we certainly needed to do. Otherwise, her quality of life would be absolutely, it's probably horrible. Yeah. What do you think about her mood as well?
Quite low.
Yeah, we actually asked the helper and the family, do you think your mother looks sad? And we said, yeah, she's crying. So the first thing to ask yourself is the pain that has never been addressed, that has never been recognized, that has never been treated, is it causing her mood to be low?
Yes, of course.
Yeah, I wish that you were there in Singapore with me because she's been untreated for years. And I don't know about you, you know, but I see this so often. And we always say we should have been treated, but why did no one refer to us? Why have we become so blind that we can walk past these people and say, it's dementia? She doesn't know. I get very upset when people tell me, your patient has dementia. Can she feel?
Wow. That one is so mean.
I don't know whether that's ignorance or that's sometimes just so hard to accept. So what do you think we should do for someone like her? This is really her pain score. I'm not joking. This is what she was like. So what should I do? What would you do? This is really her picture. It's a little bit smaller now. The edges are not so pale looking. Let me assure my colleague. It's a much better now. It looks very much better. I wish I forgot to take the picture. Yeah, so what would you do?
จะทำอะไรกับคนไข้คุณวายบ้าง
Think of the medicines that you use in cancer. You can also use it in non-cancer as well. Pain control management. Thank you. Thank you. So what would you do? What would you give?
จะให้อะไรดี
She's got swallowing impairment. She's on a tube feeding.
กลืนไม่ได้คนไข้
Constant, subcutaneous. Yes. So that would be what I would use if she was in the hospital. That's a good idea because she's in a lot of pain, right? It's 9, for goodness sake. I completely agree. So she needs round the clock pain medication. It can be subcutaneous. So if you have someone like that, yes, that's what you would do. Okay? She's on the enteral feeding. She's on the tube feeding, PG. Sorry? Sublingual what? Sublingual fentanyl. Family's quite poor. So sublingual fentanyl is a bit expensive, right? Morphine, right? Simple, good old morphine. Yeah, and so what I did was that, why am I talking about what I did? So 2 point, how much would yours start?
โอเคคนไข้เพนอย่างยิ่ง9 ใน 10 ถูกไหมเราจะเริ่มด้วยมอร์ฟีนเราจะให้เท่าไหร่
She's not kidney impaired, she's not liver impaired.
1,000 milligram
Yes, I heard some answers.
1,000 milligram right 1 milligram
Oh, okay, but she's crying quite a lot, you know. So much so that I almost wanted to start her on the subcutaneous infusion. No kidney impairment.
ไม่มี kidney impairment
No kidney impairment. I saw 20. Okay, so I basically started at 2.5 4 hourly. Yeah. Okay. So that will give me an equivalent of 15 milligrams a day. Alright? Yeah, and I asked the helper, I asked the family to give extra doses in between, particularly when we're moving her. Okay? So you will realize that you will say, but Edwin, you move her so often, so how do you do this? So I told them about half an hour after you give the morphine, then you turn her. So that was how we developed the care. Okay? Yeah. And then it's interesting because she started to not absorb very well, so the aspirates were sometimes a bit high. So what would you have done next? So actually when I added up the breakthroughs, she eventually took about 30 a day. So eventually she was comfortable on 30 milligrams a day. So she can't swallow very well. What would you do next?
คนไข้กลืนไม่ค่อยดีแล้วก็สรุปต้องได้30มิลลิกรัมต่อวันคราวนี้พวกเราจะทำอะไรอันนี้คือข้อมูลเพิ่มเติมกลืนไม่ได้
Wonderful. So a lot of our patients who are swallowing impairment, I find the fentanyl patch very, very effective. So she's currently on fentanyl and she is on 12 mics per hour every 72 hours. She continues on the morphine breakthroughs when she's turning and there's more pain, and is kept at 5 milligrams 4 hourly if needed.
เพราะฉะนั้นก็เลยเปลี่ยนเป็น fentanyl patch แล้วก็ยังคงให้มอร์ฟีนสำหรับ breakthrough pain อยู่
So after we started the medications, her pain score started to drop. And after that, when even the pain was well controlled, her family shared that she still looked very, very sad. Yeah, and there were lots of things happening in her life. Her daughter was giving birth to her grandchildren, and they could see that when the grandchildren came, she would try to reach out to touch them. So we felt she was depressed and sad. So we started. Are there any antidepressants that you use more often in patients?
antidepressant ใช้อะไรที่นี่
Fluoxetine, okay, fluoxetine. She wasn't sleeping well at night.
ไม่นอนกลางคืน
So Seroquel is a psychotropic agent. Yeah. Mirtazapine. Okay, so because you think of my patient, she couldn't sleep. She was making more noise at night. So we started her mirtazapine. How much did you start, my dear? So it's it's actually known as Remeron.
15, right? 15.
I started at 7.5 at night. She's currently on 15. And she's so well now that we're ready to discharge her. 4 years on. Her family is so upset that they're leaving us. So I've now got to take care of her by clinic.
โอเคก็คนไข้กลางคืนก็ไม่นอนใช่ไหมคะก็เลยให้ยาตัวที่อยู่บนกระดานเนี่ยก็เริ่มที่ 7.5 แล้วก็ผลที่สุดก็เป็น 15 มิลลิกรัมต่อวันตอนก่อนนอนแล้วก็ตอนนี้คนไข้ดีพอที่จะให้กลับบ้านได้
Prescribed for the long life or just like a normally treat the patient for the
Mirtazapine.
Yeah.
Very good question. So we did start at 7.5. We did stop it after 6 months, but she got more sad. So a lot of my patients with depression relapse. So depression in the elderly tends to be it does relapse quite often. So the teaching of depression in the elderly is to give for at least a year. Then you try to wean off and you see whether they do relapse or not. For her, we did try, but she relapsed, and so we put her back on. But you would also sometimes, for instance, if the patient has pain, you must remember this is nociceptive pain because it's eaten into the bone. It's also nociceptive pain because it's eaten away the skin. So sometimes you might think of an agent that will help with the mood as well as the pain. And some of the agents, for instance, so mirtazapine, I like it because it's noradrenergic. It helps with anxiety. So we felt that she was a bit anxious. So sometimes we use a drug called duloxetine.
Do we have here?
You have it in Thailand. Thailand is very advanced. Yeah, Cymbalta. It's called Cymbalta. 30 milligrams. It's beautiful because it's basically a noradrenergic agent as well, and it's very helpful for pain.
Okay.
So sometimes I use it's actually an adjuvant. So I use it not only for the mood stabilizing quality, but I also use it for a pain reliever. So you do not practice polypharmacy. I can't. So you are basically looking at the etiology. You know that possibly she has skin, there's bone. So bone is usually nociceptive, but increasingly we're beginning to realize that involvement of the bone has neuropathic pain features as well. Yeah, that although it's hard to prove, there was a study done by Professor Marie Fallon. She used pregabalin in patients with bony metastatic pain. So that study was not quite positive. But a lot of us still believe that anyone with bone affected is not only nociceptive, it's also neuropathic pain. Yes, okay. So we apply an understanding of where the etiology. So if no one had flipped her, no one would have seen this. And I'm so sorry I've kept this picture on for the last 15 minutes. It's horrifying, isn't it? Okay.
สรุปนะก็คือให้ยาตัวที่เขียนอยู่บนฟลิปชาร์ตคำถามของคุณหมอคนนี้คือแล้วให้ยานานเท่าไหร่แกบอกโดยทั่วไปเนี่ยยาต้านเศร้าเนี่ยก็จะให้ประมาณปีหนึ่งแล้วก็ลดลงแล้วก็ดูว่าเขากลับมาเป็นใหม่ไหมถ้ากลับมาเป็นใหม่ก็ต้องให้แต่ถ้าเผื่อไม่ก็แล้วไปคือทางที่ฉลาดเนี่ยเราควรจะหายาที่ทั้งต้านเศร้าด้วยแล้วก็ลดเพนด้วยซึ่งตอนนี้แผลของคุณยายเนี่ยเขาคาดว่าน่าจะเป็น nociceptive pain ซึ่งยาตัวนั้นเนี่ยก็ใช้ได้พอดีนะคะแล้วก็มีอันนึงก็คือคุณหมอคนนี้ก็ถามว่าแล้วมันจะเกี่ยวกับเรื่องของ neuropathic pain ไหมอันนี้ไม่มีคือตอบไม่ได้แต่โดยทั่วไปถ้ามันไปยุ่งเกี่ยวกับกระดูกมันก็อาจจะมีความเป็นไปได้แล้วก็มีการศึกษาที่ใช้กาบาเพนตินในกรณีของ neuropathic pain เนี่ยผลการวิจัยก็ไม่ชัดเจนว่าจะช่วยได้อะไรเท่าไหร่ก็คืออยู่ในระหว่างการศึกษาก็แล้วกันเพียงสรุปของคุณยายคนนี้คือให้ยาตัวนั้น6 เดือนแล้วก็ลดลงแล้วก็คุณยายก็เขาก็อยู่ได้ and she's still
with me.
Still with me. And quite well, right?
Very well. But although I'm giving you nice positive stories, it took a very long time to get to that stage, you know. It really was a lot of starting medications, adjusting it, giving mirtazapine, stopping it, then restarting again. And, you know, sometimes I had to use intermittent olanzapine because she would suddenly cry out. But I'm going to go on to behavior in a while. Yeah, but you do get, I think that we need to realize that the medications that we have used so fluidly in patients with cancer can also be used very fluidly with good sense by all of you in patients with dementia. They should not be denied good medications and good care.
Okay.
And it's so wonderful that you're thinking, why am I giving this medicine?
สรุปนะคือยาอะไรก็ตามแต่ที่เราให้ในคนไข้แคนเซอร์เขาก็เราควรเอาแนวคิดเดียวกันมาให้ในคนไข้ดิเมนเชียด้วยแค่นั้นเองนะคะ
Okay. Are you okay with these case studies?
Is there any question? Is there any question?
Yeah, because actually I prepared a few case studies in the afternoon, but you know, we can do them even now. Thank you for talking about bed sore care. Done. Okay, this is where my nursing knowledge comes in. Throw it at me. Yes. How would you manage the bed sore? Asking me.
Yeah. But I like your approach. Ask them.
Yes. I have a lot of nurses here. How would you recommend?
แล้วเราพวกเราคิดว่าจะดูแลยังไง
Because the surgeon says don't operate.
เพราะผ่าไม่ได้เพราะหมอไม่ยอมผ่าไปแล้ว
What would you do? Dressing. What kind of dressing would you use?
ใช้ dressing
Normal saline. Yeah, we don't use the chlorhexidine anymore, right? Yeah.
ใช้ normal saline
I do know my wound dressing. Not to worry. So we normal saline. She was a bit wet in the beginning. So
แรกแผลค่อนข้างแฉะ
So what did you use?
แล้วเราจะทำยังไง
Do you have caltostat here? Calcium alginate? We use that as well. So we packed and we basically went in to check. Then you know about the positioning, right? Yes. So we basically taught the helper to move her half an hour after morphine, and after that when she was on the fentanyl patch, because she was more stable, we basically positioned every 2 hours, and then at night, she has a sort of a dynamic ripple mattress to help as well. So the sore can't heal because we can't graft it. It's not healthy enough to graft anyway, but we have prevented sores anywhere else. I think that's the key, right? Yeah, so the pressure points, the head, the scapula, your sacrum, your hips, and your malleoli, right? The 5 major areas. Back care is when we have even sores on our ears, right? So we always check that, and families need to be educated. I have a patient that day who told me, Dr. Ham, why don't you turn my mother less since she's in so much pain? I was like, first of all, I'm doing a bad job because your mother's in pain. Number 2, I'm doing a bad job because I haven't taught you how to manage your mother's pain when you're turning.
Okay. Right. สรุปนะคะก็ให้ล้างแผลโดยใช้ normal saline แล้วก็ตอนแรกๆที่แผลแฉะก็ใช้แคลเซียมอัลจิเนตอะไรพวกคุณรู้ดีกว่าคนนี้แล้วทีนี้พอทำไปเนี่ยแผลเขาก็จะดีขึ้นอย่าลืมให้มอร์ฟีนก่อน30 นาทีแล้วค่อยพลิกตัวยังคงพลิกตัวทุกครึ่งชั่วโมงเพื่อป้องกันการเกิดแผลกดทับในบริเวณอื่นตำแหน่งแผลกดทับทุกคนต้องรู้นะและต้องบอกกับญาติด้วยว่าสาเหตุที่เราต้องพลิกตัวเขาถึงแม้ว่าจะดูเขาก็ยังมีครวญครางอะไรอย่างเงี้ยเป็นเพราะเรากำลังป้องกันให้เกิดแผลกดทับเพิ่มขึ้นเพียงถ้าเราทำอย่างนี้ไปได้เรื่อยๆแผลที่เป็นอยู่มันจะค่อยๆสมานหวังว่า
Okay, this is another one of my patients. She basically was an amazing lady. She was a school teacher. And her favorite hobby was that she loved to play golf. In fact, the family are such athletes that the daughter is actually a sports journalist in Singapore, a quite famous one. So she loved to play golf, but as the sad part was that she did develop dementia. So she had a mixed etiology, Alzheimer's with vascular dementia. So we don't know which made it worse. When she came to me, she was already on artificial feeding, and she was already in fast stage E. So there was absolute no smile, and I was told by some of her ex-students who were my seniors in the hospital, so she taught many doctors, that she was the sweetest and most loving teacher, never scolded. Yeah, so, but what happened was that one day she was referred for pneumonia, and she came to Tan Tock Seng for pneumonia, and this was the time that she came to me. She was persistently moaning and groaning, and the doctors asked me, Ellen, shall we start Seroquel? Because she's moaning, she's groaning, the neighbor can't sleep.
That loud? That loud?
That loud.
Okay.
Go through your head the Baynet score, right? Okay.
Yeah.
But the thing that I want to challenge all of you was, I get asked this a lot. She's disturbing the neighbor. Even the family says, the family was very sweet. They apologized and said, I'm so sorry for my mother's loudness, do you want to give her something to keep her quiet? Even the family. Okay, so let's go back to basics. Always go back to basics, okay? We lose our way when we make assumptions. One of my bosses in Canada taught me, Ellen, you do your patients a misservice when you assume. Never assume. Go and see the patient. So I'll show you what my patient looked like. This is not her, but okay, remember she's a golfer, right?
Yeah.
By the time I saw her, limbs are stiff. I can't move her upper limbs. She's so tight, I can't move it. Her legs are drawn up to her chest. She's like she's a very misshapen ball. I could not examine her chest anteriorly because her limbs are so tight, I couldn't move it. It was so tight and she grabbed her hand so tightly that her fist had sores. She's a golfer, And this is what has happened to her. So, you think what's the cause of her moaning and groaning?
May I a little bit? คุณ แอลเนี่ยเป็นนักกอล์ฟเป็นครูแล้วก็เป็นครูที่ลูกศิษย์รักแล้วก็เป็นครูที่ดีแล้วเธอก็อยู่ๆวันหนึ่งเธอก็เป็นดิเมนเชียเนื่องมาจากสโตรกแล้วก็มาแอดมิดแล้วก็ตอนที่อาจารย์เขาไปเจอเนี่ยก็คือนอนในท่างอกองอขิงแล้วก็โดยเฉพาะด้านบนเนี่ยมือเขาจะประสานไว้ในท่านี้แล้วก็อาจารย์เขาไม่สามารถที่จะผายมือออกได้จึงไม่สามารถตรวจร่างกายบริเวณเชสได้พวกเราคิดว่า so the question is what can we do right
Basically they call you and ask you
อ๋อแล้วคนไข้ก็ครวญครางตลอดเวลาร้องดังมากจนกระทั่งรบกวนเพื่อนบ้านแม้แต่ลูกก็ยังมาหาหมอว่าจะทำไงให้คุณแม่ไม่ร้องดัง
Can I start Halo Berry doll
so เราจะทำไง what can we do for her
You want to ask me some questions about her how she was when I saw her
yes
Please do Face thank you So her face she just looked just like grimacing on and off
so it's 1 out of 2หน้านิ้วคิ้วขมวดไหมหายเป็นเพียงเยอะได้1 ใน 2แต้มเอาตารางนั้นเปิดขึ้นมาดูอยากรู้อะไรอีกถาม breathing
She really started to hyperventilate when I turned her
ก็หายใจเร็วทุกครั้งที่จะ
The posturing was absolutely stiff she really disliked it when I turned her so I had to get her helper from the Philippines her name is Lisa so Lisa actually turned her and she was a bit more comfortable but her posturing was very tense and it increased in rigidity when I turned her
เวลาอาจารย์เขาจะไปช่วยพลิกตัวหรืออะไรเนี่ยเขาก็จะยิ่งหดเกรงแข็งแต่ถ้าให้พี่เลี้ยงก็จะค่อยยังชั่วอะไรเงี้ยก็ได้2/2อะไรอีกNegative vocalization
Negative vocalization was 2
Consolability cannot 2 out of 2 so it is 9 out of 10 again สรุปได้9 จาก 10
So what would you start
แล้วโอเคประเมินแล้วรู้แล้ว9 เต็ม 10ทำอะไรต่อ
Panadol Would you give Panadol No right A strong opioid. Don't give the chickadee stuff. We always learned in the pain ladder, and that was why Kathleen Foley created the pain ladder. Give the potency or the strength of the pain medicines should be equal to the pain experience, right? Okay. This is bad pain, right? So I did the same. You know, she was in the hospital then, and I started her on the sub-QT. She had kidney impairment.
มี kidney impairment
creatinine clearance was less than 30. So I gave her infusion, subcutaneous infusion of fentanyl. Yes.
มี kidney impairment ก็เลยให้เป็น fentanyl แทนแล้วก็เป็น sub-Q.
And you know the moaning and groaning?
Stop.
I saw her in the afternoon. It's completely softer.
Okay.
It didn't stop completely. It took me about a few days.
But better.
Much better.
ก็พอเริ่มให้ยาก็เรื่องครวญครางก็เบาลงแล้วก็หลังจากนั้น2-3 วันก็ยิ่งค่อยๆหายไป
Contractures can be so painful that my colleagues in neurology actually Botox the muscles to release the tension in the muscle. So it's really painful. In fact, one of my first patients in geriatrics was a lady with advanced Parkinson's, and she was actually a case I was going to share, but it's very much like this, severely contractured and in severe pain. And she just needed opioids. And this lady's family, Mrs. Y's family, was so amazed at the dramatic change in her. You know, and she actually went home. She was under my palliative team. She had several bouts of antibiotics. We took care of her for 1.5 years. No hospital admission. She died at home, very comfortably.
สรุปคุณวายเนี่ยได้กลับไปดูแลที่บ้านนะคะแล้วก็ได้อยู่ที่บ้านเป็นเวลา1.5 ปีคุณแอล เป็นเวลาปีครึ่งก่อนที่จะจากไป แล้วก็ไม่ต้องกลับมาเข้าโรงพยาบาลอีกเลย
Okay, so does this convince you that you can manage pain? Yes. Can you? We can speak for our patients, right? We can translate this, right? Yeah, and we can really give very good care. Yeah, this is really inspired by all my nurses because I learned everything from them. So I always say this: you speak on behalf of all your patients, and the way that you care. I've realized that the doctors that I look up to, it's not their words, it's their actions that counted the most. That really inspired me. I'm doing what I do today because I have so many people who inspired me, and you are all inspirations and role models where you are. I think that you need to remember that dementia is an illness. It is not something that anyone ever wants, and that this was a beautiful. This is Professor John Wyatt. He's a neonatologist, so he's a bit like Professor Shriving. He started out in pediatrics, but he also is a very strong palliative advocate. So he said this: it doesn't matter about dementia. Whatever happens to my brain, my experiences, my thought processes, and my memory, my personhood is secure in the eternal knowledge and covenant love of God Himself. That I will always be me. And we have been blessed with an amazing job to help our families, to help our colleagues remember that the patient is still living and still needs the best care that we can give them. Okay? So we can do this. Alright? Yes. Okay, we're going to stretch out a little bit. And I'm going to change slides and we're going to talk about the next set of unmet needs. Are you okay?
It is already.
Lunchtime.
It is 12. Half 12.
Yes, hang on. There was a good question. Yes. Yes. So she was on all the vascular medications. On atrial fibrillation, we stopped the rivaroxaban. We stopped it because she was getting a lot of not hemarthrosis, she was getting a lot of ecchymosis. So she was getting more anemic by the bleeding into her skin. And the helper couldn't quite control it. She wasn't mishandling her, it's just that her skin became so thin. So we stopped it, but we were well aware that at that stage, the medications were not helping. When I took her over, she was also on Mementin. Because she was a school teacher, so the government pays a lot of these medications, but Mementin didn't help. So by the time I took her over, I told the family, and you know what they did? They bought a lot of Mementin, they gave it to me. It's like, if you have any other patients, it's like, no, I don't have any other patients who need Mementin. I maybe should start it myself now. Yes. No, so we didn't stop the hypertensive medications. So palliative care doesn't mean that you stop all medicine. So we looked through the list. So we actually, as she clearly was getting worse, we stopped rivaroxaban. We basically we continued the high blood pressure medicines because we didn't want her to get another stroke. Yeah. We basically stopped the Mementin clear on in Tantoxing. And basically with the PEG tube feeding, we also had to drop the volume because she couldn't absorb towards the end of her life. Yeah, so the medications change as your patient changes. We don't take them out all the time. We did, however, take out her cholesterol medicine, the atorvastatin, because we knew that her prognosis was not going to be very long.
คุณหมอเขาถามว่าเนื่องมาจากว่าเขามีโคมอร์บิดโรคอื่นเนี่ยยาต่างๆที่ได้รับเนี่ยยังคงให้ไหมสรุปอาจารย์เขาบอกว่าถ้ายาตัวไหนไม่ได้ประโยชน์ก็เอาออกแต่ยาตัวไหนยังคงต้องให้เช่น high blood pressure เนี่ยก็คงต้องให้เพราะว่าเราไม่อยากให้เขาเกิด stroke ซ้ำอีกเรียนสรุปก็คือว่าเวลาเราไปเจอคนไข้ถ้าเขามีโคมอร์บิดเราก็เอายาเข้ามารีวิวให้หมดอะไรที่เป็นระยะยาวอะไรเงี้ยก็หยุดหรือให้ไปก็ไม่ได้ประโยชน์ก็ควรจะหยุดค่ะเรียนคอนเซ็ปต์ก็คงเป็นลักษณะอย่างนั้น
Yeah. Is there a question with regards to the medicines that you were worried about?
Anticoagulant, because she have an AF
Yeah.
and has a previous stroke, and she high risk of recurrent stroke.
Yes.
So if we stop the
river, right? Yeah. So it was really a balance of the risks and the benefits. Yeah, so we really felt that because she was so advanced in her illness already, and we did continue it for about the first 6 months that we looked after her, but as she developed more and more bleeding into her skin, we decided we needed to stop it because of the risks.
And about tube feeding, is there any circumstances that tube feeding is preferred, such as if the patient is severe pressure sore and her nutritional status is poor? Okay, we can give her the tube, improve her nutrition via tube feeding. This is sensible.
So the question is whether tube feeding actually improves nutrition and helps with the healing of pressure sores. I think that's a very good question, and that's something that we all hope for when we do put in tube feeds, be it through the nasogastric region or the percutaneous region. However, studies, and I did put one of the most important studies in your packet by Thomas Finucane, studies have increasingly shown that patients at the last phase of their life do not benefit from the enteral feeding. Actually doesn't heal the sores. It does not actually prevent infections, and that has been shown. So the study was actually retrospective. They actually studied the patients in the nursing homes and came to that conclusion. Subsequently, a lot of us did studies to see whether it is correct, prospective studies, and unfortunately the evidence is quite sure that it actually doesn't heal the sore. Remember my Mrs. Y, the bed sore? She's still on enteral feeding, my dear, and the sore is still there. Yeah, I think that what really helped with the slight healing and the prevention of the sores is really the positioning. Is really daily checking of I'm not saying that the sore developed because the helper was, negligent. It happens, and it's multifactorial. And I think that to hope that tube feeding alone heals it, unfortunately, the evidence is still not for it. Yeah, so that's why I try not to put feeding tubes into my patients. I try to balance the risks and the benefits. Some families will still insist on it, and we need to respect that decision. But with tube feeding comes a lot of problems. A lot of my patients drown in their secretions. Yeah, and they can't absorb and they get more and more infections. I have a patient at home now. She keeps spiking temperatures of 39 degrees. So the daughter is anxious, the helper is anxious, and the team is also struggling to support all of them. So sometimes we create problems, we as doctors, we put it in and we create all these problems, and it's like putting a nephrostomy for a blocked, for hydronephrosis because of cancer blockage. And my urologist saying, Ellen, how can I prevent my patient from coming in with recurrent fever? You put in a tube, you're gonna get fever. I mean, when you tell your patients that you're gonna put in a nephrostomy, and you know that the disease is in the liver and the lung, and you put this in, then evidence has shown that even when we unblock malignant hydronephrosis, mortality is still going to be very poor. Patients are going to come in with catheter-associated infection. We need to own up to what we do and manage it.
คุณหมอถามว่ามีเงื่อนไขอะไรไหมที่เราควรให้ NG tube นะอาจารย์เช่นยกตัวอย่างเช่นคุณยายที่มีแผลเนี่ยภาวะโภชนาการก็แย่แล้วเราก็ความรู้เรามีว่าแผลจะสมานได้ดีหากภาวะโภชนาการดีขึ้นเพราะฉะนั้นการให้ NG tube ก็ฟังดูมีเหตุมีผลอาจารย์เขาก็ให้คำอธิบายว่ามันมีการวิจัยย้อนหลังเป็น retrospective เนี่ยพบว่าการให้ NG tube ไม่ได้ช่วยทำให้ภาวะโภชนาการดีขึ้นซึ่งจะไปส่งผลให้แผลนี้ดีขึ้นตามมาคราวนี้ก็ยังมีคนติดใจเรื่องนี้อยู่ก็มีการทำวิจัยอีกกลุ่มหนึ่งก็คือทำเป็น prospective ไปข้างหน้าก็ปรากฏว่าผลออกมายืนยันเหมือนกันว่าการให้ NG tube ไม่ได้ทำให้ภาวะโภชนาการดีขึ้นและไม่ส่งผลให้แผลหายได้เร็วขึ้นเพราะฉะนั้นยังยืนยันว่าไม่มี point จะใช้ไม่ว่ากรณีใดมีคำถามอะไรไหมก่อนเราจะไปทานข้าว
It's okay. I'll just so is the PNET the same as the numerical rating score, and can we then use that measure? The PNET is, I suppose it looks like the numerical rating score, right? Again, if the patient has a score like ours of 9, 7 to 10, then we would advise the medication to be equal to the intensity. If your patient has 1, then I would recommend paracetamol. So the long answer to your question is yes. So I like the use of tramadol as well in my patients with moderate pain, because it also actually moderates the descending pathways of pain. It inhibits the reuptake of serotonin and noradrenaline. So also very helpful for pressure sores of moderate intensity. So yes, you can use that approach.
อาจารย์น้ำทิพย์ถามว่า PaNET เนี่ยเทียบเคียงกันได้เท่ากับ0 ถึง 10 ของ Pain Score ที่เราใช้ไหมแล้วถ้าเผื่อมันใช่เราใช้แนวทางการแปลการตีความหมายเหมือนกันเพื่อที่จะให้ยาควบคุมความปวดไหมคำตอบคือใช่เช่นถ้ามัน8 7 8 9อะไรแถวนี้ก็คือปวดอย่างยิ่งก็ต้องไปให้แลนเดอร์สูงๆแต่ถ้าออกมาเป็น1อาจารย์บอกส่วนตัวเขาก็อาจจะให้แค่พาราเซตแค่นั้นเองหรือถ้ามันมากกว่านั้นนิดหน่อยก็อาจจะนึกถึงtramadol อะไรอย่างเงี้ยค่ะ
What I'll do is that I will change the schedule a little bit. Is my pace okay? Are you all comfortable with the pace that I'm going?
สอนขนาดนี้โอไหมโอ
Okay.
Yeah.
Now I was supposed to do case studies in the afternoon. I've got 2 more lectures to give, so you can imagine that we'll stay here until 10 tonight, which is okay for me. But this is what I'll do. I have incorporated a lot of case studies into my talk. So would you like to talk through that, and that will be okay for all of you?
Yeah, I think so.
Do you feel that you've missed out if you don't break out into groups and do case studies?
I think it can go along with your lecture, and then maybe
We will. So can you help me out
interact more?
by basically sharing more with me? Would that will be okay?
You have to interact more. คือเราจะไม่ทำกลุ่มเป็นแยกกลุ่มชัดเจนเพราะว่าเรื่องเวลา
Would that be okay with
เรา
all
จะ
of
ทำไป
you?
พร้อมกับอาจารย์บรรยายพวกคุณก็ต้องตอบสนอง
Because
มากขึ้น
I have so much to share with you. So
Then you have to stay for a week rather than 2 days.
So I tell you what, do you want to have lunch first, and we'll come back and continue, okay? And certainly we will continue to talk about my case studies. Lunch break is usually about 1 hour, right? 45 minutes. So we come 1:15, okay with you all? Thank you.